Hello and welcome. I'm your ENT faculty, Dr. Sanjay Aggarwal, and I've been teaching ENT for almost 2 decades, more than almost 19 years now. And today I'm going to talk about clinical based questions directed towards MCI exam as well as NEET exams, because now we all know that this is an era where they've started asking image based along with clinical questions. So we are talking about clinical questions, and this is part 3 in the series. I've already taken part 1 and part 2. In part 1, I had talked about questions from ear, clinical questions from ear. In part 2, I had talked about clinical questions from the nose and sinuses. And in this part 3, we are going to take questions only from the throat. And so you must watch all the 3 parts to get an idea what kind of clinical questions they can frame from ENT for NEET PG as well as for MCI exams. But before that, I must tell you about this course called Focus NEET PG 2022. This course has already started in August. The ENT part is going to start on 14th of December to 26th January. And this is going to be almost 30 hours of ENT, which is appropriate for completing the entire ENT in a detailed manner. So quite useful. If you have not joined, I'll highly recommend that you join this if you are targeting NEET PG 2022. But for this, this is another important thing. Iconic subscription, you know this, that we are giving you 2 things. We are giving Unacademy subscription plus an app, and this combo is really become a hit among students. They really love this combo, and there are many packages for 1 month, 3 months, 6 months. So you can really check on the website of Unacademy and see what's useful for you. Very, very useful. And this is a third thing we're coming up. It's a marathon batch. As the name tells you, we're going to do all the 19 subjects very fast, and they're all MCQ based. ENT part is going to start on 30th of November, and they're going to be 5 sessions of 1 hour each. So that means total of 5 hours. And in 5 hours, we are going to do almost all the topics of ENT and most of the questions that are needed. Right? So with this information, we'll start with clinical based questions from the throat. First question. It says, a 40-year-old hearing loss, nasal blockade and epistaxis for few days. There is no other complaint. Systemic examination is normal. Anterior rhinoscopy shows few clots in the nasal cavity. Otoscopy shows dull tympanic with grade 2 retraction. Nasal endoscopy and nasopharyngoscopy was done, which showed small swelling. Biopsy was taken and sent for histopathological examination. Oral cavity, oropharynx and laryngopharynx were normal. Histopathology examination report suggested undifferentiated squamous cell carcinoma. True of this patient is A. Nasopharyngeal carcinoma. B. Retropharyngeal lymph node is the first node to involve in this. C. Sphenoplata in foramen is the most common site. And D. Trottos Triad may be seen. Now please make a correction. The question should have been not true. Please add not. Not true of this patient, which means there are 3 options are true, 1 is not true. Now it's a very typical history of a nasopharyngeal carcinoma which is seen in adults. You know, nasopharyngeal carcinoma has bimodal spread or incidence. It is seen either in people less than 20 years or after 30-35 years, around 40 years. So this is that age group. And nasopharyngeal carcinoma is most commonly seen in fossa of Rosenmuller, arises from fossa of Rosenmuller, which is just behind the station tube, and therefore the station tube gets blocked, and if the station tube gets blocked, hearing loss. So this is one of the complaints, hearing loss. See, hearing loss and nasal blockade and epistaxis, this combination in adults is very typical of a nasopharyngeal carcinoma. So you might get confused that there is a throat problem, nose problem, nasal blockade epistaxis, and ear problem, hearing loss together. This is not a nose problem, this is actually a nasopharynx problem. It comes from through the nose, because nasopharynx lies behind the nose. So if you have a problem in the nasopharynx, the bleed, the discharge will going to come from the nose, through the nose, and it gives appearance or suspicion that it could be a nasal problem. No, it is nasopharyngeal problem which is part of the throat. So when you have throat and hearing loss together, the likelihood in adult, then likelihood of nasopharyngeal carcinoma is very, very high. And if you have a hearing loss, ear and throat problem in children, then the likelihood of glue ear with adenoid hypertrophy is very high. But this is adult, so no adenoid. This is, we are suspecting a nasopharyngeal carcinoma. And look at the other things. That's why nose is not, see, anterior rhinoscopy shows few clots because the blood is coming from the nasopharynx. Otherwise, it is unremarkable. The nose is normal, and on endoscopy, nasopharyngoscopy, they could see a small swelling, growth kind of thing, which biopsy, and the biopsy says it is undifferentiated squamous cell carcinoma. Now, undifferentiated squamous cell carcinoma is the most common carcinoma in nasopharynx. This is a very strong clue, because otherwise undifferentiated squamous cell carcinoma in the head and neck region, this area is quite uncommon. So straight away we know it is nasopharyngeal carcinoma because it is undifferentiated squamous cell carcinoma, the most common type. This is an MCQ also. So yes, A is true. Then in nasopharyngeal carcinoma, the first lymph node involved is the retropharyngeal lymph node. That is also true, but the site is not this. I told you the site is fossa of Rosenmuller, not sphenoplateau and foramen. So this is a wrong statement, and therefore the correct answer. And Trottos Triad, we all know, is a very important feature of nasopharyngeal carcinoma. Right. So C is the correct answer. C is not the correct statement. Sphenoplateau and foramen gives rise to juvenile nasopharyngeal angiofibroma. I'm pretty sure that most of you know this. It is a most common site of angiofibroma, not a nasopharyngeal carcinoma. Nasopharyngeal carcinoma comes from fossa of Rosenmuller, which is written here. Right. So simple question, clinical based question from nasopharynx or throat. Next one. A 50-year-old Chinese had cervical lymphadenopathy, hearing loss, pain on the face, regurgitation to fluid and hypernasal voice. No other ENT or systemic complaint. Systemic examination vitals are normal. Anterior rhinoscopy had few clots in the nasal cavity. Soft palate palsy was noted. Tympanic membrane is retracted and has loss of cone of light. Rinne's tuning fork was negative and Weber's was lateral to the same site. Which of the following is true in this patient? Now once again, first a diagnosis and the situation then. See, again it is adult Chinese and cervical lymphadenopathy with hearing loss, pain on the face, regurgitation of fluid from the and hypernasal voice. So cervical lymphadenopathy is the first presentation again of a nasopharyngeal carcinoma. Nasopharyngeal carcinoma. So this is again nasopharyngeal carcinoma, very, very clear. Hearing loss and throat. Remember I told you is a very strong, in adult is a very strong suspicion. And nasopharyngeal carcinoma are very common in Chinese people. So again, it's a lot of things to tell you. But this nasopharyngeal carcinoma has hearing loss in this patient, pain on the face and regurgitation of fluid and hypernasal voice. Right. So these are the additional problems. There is no other symptom except short palate palsy. Because there is a short palate palsy, that's why there is regurgitation of fluid and hypernasal voice. These are the two features of short palate palsy. Short palate palsy can cause regurgitation, it can cause hypernasal voice. And both are present in this patient. And this is retracted tympanic membrane. As you can see, that means the station tube is blocked. It is not functioning. That's why there is a hearing loss also. Hearing loss is because of this retracted tympanic membrane, as it's shown. There is loss of cone of light. And Rinne's is negative and Weber's is lateralized to the same side. This suggests it is conductive hearing loss. I'm sure you know this. You have to know this to be able to crack that. So it is and this hearing loss they are talking about is conductive hearing loss. That means it is a middle ear disease problem, and that we know because it is a retracted tympanic. So this is suggesting there's they are matching, the two are matching, that in retracted tympanic membrane it's perhaps a glue ear, it's perhaps a serous otitis media that is happening. So nasopharyngeal carcinoma is causing blockade of the station tube. That's why there is hearing loss and retracted membrane, loss of cone of light, and conductive hearing loss. It is also causing soft palate palsy. That's why there is regurgitation and hypernasal voice, and there is also pain on the face. When does all this happen? This is it nasopharyngeal carcinoma with spread to the parapharyngeal space, or spread to the fossa of Rosenmuller, or spread to the sinus of Morgagni, or spread to the pterygoplatan fossa? And the answer is C, spread to the sinus of Morgagni. Now, when this nasopharyngeal carcinoma, which arises from the fossa of Rosenmuller, which I told you in the last question, spreads to the sinus of Morgagni, it causes a triad called Trottos Triad. And Trottos Triad has three features. One is soft palate palsy. As you can see, there is a soft palate palsy straight away. That's why there is a regurgitation and hypernasal voice. Hearing loss. Again, this patient has a conductive hearing loss and retracted tympanic membrane, station tube blockade, all that, glue ear, and facial pain, as is written straight away. So this is a patient of nasopharyngeal carcinoma who has a Trottos Triad, these three features, and this happens when the tumor spreads to the sinus of Morgagni. I'm sure you know sinus of Morgagni is a space above the superior constrictor muscle. Between the skull and the superior constrictor muscle, there is a space called sinus of Morgagni, and through this space, eustachian tube travels. So when the eustachian tube gets blocked, that's why hearing loss and conductive hearing loss and all that. And then palatal muscles are there, especially levator palati muscle, and very close by is also the tensor palati muscle. So these muscles of the palate gets involved. That's why palate palsy, causing regurgitation and hypernasal voice. And just outside this space, this sinus, there is a mandibular nerve. Just outside, it's not passing through this, but it's outside. So when the tumor comes out of this, it involves the mandibular nerve, and that causes facial pain, because mandible supplies the lower 1/3 of the face sensory also. That's why. So that's why it is sinus of Morgagni syndrome or Trottos Triad. Now when the nasopharyngeal carcinoma spreads to the parapharyngeal space, now parapharyngeal space has 9th, 10th, 11th, 12th nerves. So these are the symptoms of 9th nerve. Like 9th nerve, the patient may have loss of sensation in the throat, oropharynx. Then 10th nerve can cause voice change, laryngeal problems. 11th nerve can cause shoulder movement, trapezius, sternocleidomastoid problems. And 12th can cause tongue muscles, so tongue movement may be affected, tongue may get pushed to the same side and all that. So none of this is there. And also sympathetic chain. Parapharyngeal space also has sympathetic chain. And when the sympathetic chain gets involved, then there is Horner's syndrome, ptosis and all that. And none of them is there, no Horner syndrome in this patient. So very clearly it is not parapharyngeal space spread. And in parapharyngeal space, you don't have hearing loss and palatal palsy, facial pain and all that is not seen. So first one is ruled out. Now, it does not have to spread to the fossa of Rosenmuller. It arises, nasopharyngeal carcinoma, as we discussed already, arises from the fossa of Rosenmuller. So that's the first thing. So to say that it spreads to the fossa of Rosenmuller is a wrong sentence in itself, cannot be true. And if it spreads to the pterygoplatan fossa, then pterygoid muscles are there, trismus, pterygoid muscles, trismus takes place. Then there is maxillary nerve there, maxillary nerve gets involved, and the symptoms of that arises. And none of them is given here, no trismus, no locked jaw. All that happens when the tumor spreads to the pterygoplatan fossa, where you have trismus or pterygoid muscles. So very interesting question, I thought, very conceptual. But when you know this and you revise this kind of things, it gives you a lot of information, and it really opens up your mind to this kind of diseases. And it tells you that nasopharyngeal carcinoma can actually spread to the parapharyngeal space, can go to the pterygoplatan fossa, can go to the sinus of Morgagni, and they can cause what kind of symptoms? How do you know? So that's the main thing. How do you know it is parapharyngeal space? 9, 10th, 11th, 12th nerve symptoms and Horner syndrome. How do you know pterygoplatan fossa, pterygoid muscles, and maxillary nerve? How do you know sinus of Morgagni? All is given here, Trottos Triad. So these are things that tells you where the tumor has spread clinically. Of course, confirmation is always done with uh, biopsy, histopathology examination, and MRI. MRI will show you the spread, and then you accordingly stage the disease and go for the treatment. The treatment for nasopharyngeal carcinoma is chemoradiation. That's a very common question. Chemoradiation is the treatment of choice for nasopharyngeal carcinoma. You should know that. However, we go to the next question, third one. A young plumber presented with incomplete opening of the mouth for a few weeks. He also complains of sensitivity to spicy food. When he eats spicy food, it's very sensitive in the throat. No dysphagia, no difficulty in swallowing, no voice change, no weight loss, no systemic diseases. He is chronic smoker and has a habit of eating betel pan, chewing for many years. On examination, there is a whitish and thickened anterior pillar of the tonsil and soft palate. There is no other significant finding, most likely diagnosis. I thought it's a very common disease in India, and I thought that you can easily identify with the history. So it's a low socioeconomic person who is used to eating pan and smoking, weed is usually maybe cigarette also, and has difficulty in opening the mouth and sensitivity to the spicy food, and there is a thickening of the anterior pillar of the tonsil and the soft palate. So most likely diagnosis is submucosal fibrosis. We know that. This is a very typical classical presentation in submucosal fibrosis. This thickened and whitish, this is fibrous tissue. This is fibrosis. Fibrosis deep to the mucosa of that area, that's why submucosal fibrosis. We all know fibrous tissue appears whitish and thickened, and it's like a rope tied, and this is what is preventing from opening the mouth. Opening the mouth is prevented because of this fibrosis, especially on the anterior tonsillar pillar. If you have fibrosis only in the soft palate, then this trismus or difficult to open in the mouth is not present, because anterior tonsillar pillar, they prevent the two upper, it connects upper jaw with the lower jaw, kind of. So it prevents, if they get fibrous, then your jaws cannot move apart and they cannot open. That's the main reason why the people with submucosal fibrosis have difficulty in opening the mouth. And these people are very sensitive to spicy food. The moment they put the food in the mouth, especially spicy food, it causes a lot of, irritates the nerve and causes a lot of sensation, which is intolerable at times. Leukoplakia, on the other hand, can be a very similar presentation, but it is mainly seen in buccal mucosa, more commonly, and it's not thickened. In fact, it is keratotic, very thin keratotic film. It's like a film, not a thickened. It's not fibrotic. In other words, it's not fibrotic. And it's very limited area in leukoplakia. The area involved is very limited. It can have patchy, one patch here, another patch here, another patch there, but each patch is not very widespread, usually very small patches. Whereas submucosal fibrosis is continuous thing, starting from one area and continuously can spread throughout the oral cavity. Erythroplakia is very similar to leukoplakia. The only thing difference is that it is reddish in color. Erythro means, inflammatory, reddish, hyperemic in color, whereas leukoplakia is whitish in color. And carcinoma, of course, is a very, either is a proliferative growth or it is ulcerative growth. We all know carcinomas, they are either proliferative, ulcerative, and they'll cause weight loss. There is no weight loss in this patient, weight loss, and it's very easy to diagnose a carcinoma, isn't it? Right. Now, in most of these conditions that are given, the history is very similar. The profile, patient is usually smoker, alcoholic, chewing of tobacco, pan and all that, and may have opening difficulty of the trismus, that is, which is very prominent in submucosal fibrosis. In rest of them, opening of the mouth is not difficult. Usually, this symptom of trismus or lockjaw, as we call it sometimes, is not very profound in rest of the conditions. However, in advanced conditions, they may also have trismus, but usually not. In submucosal fibrosis, this is one of the most common complaints. These two, sensitivity to the spicy food and difficulty in opening the mouth are the only two complaints actually in submucosal fiber. There is no other complaint. The last choice is carcinoma, and rest all the three are pre-malignant conditions. All three of them are pre-malignant, and that's why they are important. Which among the three is the most pre-malignant condition? If I ask you, then erythroplakia among the three is the most pre-malignant condition that you should know about. We'll shift to another question. Question number 4. A 30-year-old presented to emergency with severe throat pain with odynophagia and muffled voice since morning. There is history of recurrent pharyngotonsillitis for few years. Fever is 100 degrees Fahrenheit. Tonsil is pushed medially till uvula, and the uvula is pushed onto the opposite side. There is no other significant finding. True in this case is most common pathogen is Streptococcus pneumonia. Immediate incision and drainage should be done. CT scan of the oral cavity and throat should be done. All are true. So first of all, what do you think is the diagnosis? And then what is the correct answer? It's an adult, came to the emergency with severe throat pain. So obviously the throat pain the patient is not able to tolerate. And there is also difficulty or pain during swallowing and muffled voice. You know what is muffled voice? When you're eating something in the mouth and you try to speak, that voice which is not very clear is a muffled voice. So there is something in the mouth that is preventing the movement of the tongue. There's either you're eating something, there is a food inside, or there is some swelling or a growth or space occupying lesion in the throat, then you have muffled voice. So it tells you there is a swelling or growth. If you're not eating something, then there has to be some swelling or growth, space occupying lesion, which is causing pain and odynophagia and fever also. And patients have been having recurrent tonsillopharyngitis, recurrent infections of the throat has been happening for a few weeks. Now the finding is a clincher that the tonsil is pushed medially and the uvula is pushed onto the opposite side. Now this tonsil pushed medially and uvula pushed to the opposite side are very commonly seen in tonsillitis or tonsillar hypertrophy, you can say. But in tonsillar hypertrophy, it is very uncommon in adult. We all know tonsillar hypertrophy is very common in children, uncommon in adult. It is never unilateral. Tonsillitis or tonsillar hypertrophy is usually bilateral. But patient can have these things: sore throat, dysphagia, muffled voice. All this is possible. Fever is also possible. But it is unlikely to be tonsillitis because age and it is one side, not bilateral. Second thing is parapharyngeal space abscess. Parapharyngeal space abscess, because parapharynx space is outside the pharynx. So parapharyngeal space abscess can lead to these symptoms, but they are not so severe. Pain throat is possible, but severe pain throat in parapharyngeal space abscess is uncommon. Dysphagia is possible, odynophagia is uncommon. Muffled voice is almost never seen because there is nothing inside the throat, so muffled voice will not happen. And yes, it can arise from this. Past history of pharyngotonsillitis can cause parapharyngeal space abscess and fever can happen. But tonsil can be pushed medially. In parapharyngeal space, tonsil is pushed either medially or anteromedially. It can be pushed medially or anteromedially, but certainly not up to the uvula, because I told you parapharyngeal space is outside the pharynx. So no matter how big the abscess is, it cannot push the tonsil up to the uvula so much so that the uvula get pushed to the opposite side. So this is unlikely, possible but unlikely. The third is quinsy, which is inside peritonsillar abscess, which is inside the pharynx, and it's a very painful disease, and that's why it's possible that patient of quinsy can have severe pain in the throat. It's called hot potato condition. We all know quinsy is called hot potato condition because of severe pain and odynophagia. Both are there. And muffled voice you can have in quinsy because tonsil gets pushed medially. And quinsy is also due to recurrent pharyngotonsillitis, same cause. And quinsy is the most common condition out of the three, which is likely to push the tonsil till the uvula and pushing the uvula onto the opposite side, and it is only one-sided swelling. So quinsy is the most likely diagnosis condition in this patient, right? So this is quinsy in our case. And quinsy is caused by Streptococcus pyogenes, okay, not pneumonia. So A is not true. In quinsy, immediate drainage has to be done, so this has to be a correct statement, and it's a clinical diagnosis, so you don't have to do CT scan. In quinsy, we don't get it done, so all cannot be true. So B is the correct answer. Incision and drainage followed by interval tonsillectomy is done in quinsy. You know this. In quinsy, we have to do what is called interval tonsillectomy after you have done the incision and drainage, which is tonsillectomy done after 6 weeks of this problem. So very clearly a case of quinsy, but really you have to be able to differentiate quinsy from parapharyngeal space abscess. I told you in parapharyngeal space abscess, the throat symptoms are less common, fever is more, and in quinsy, throat symptoms are more, fever maybe not that much, right? But if there is any doubt, you can always get a MRI done to rule out the two. Moreover, quinsy you can drain. If you put a needle, you can aspirate the pus from the tonsil. In parapharyngeal space, you cannot aspirate the pus from the tonsil. So that can also help you in diagnose as well as treat the condition. Next one. A 2-year-old child was brought to the emergency with respiratory distress and fever and voice change. Small child has respiratory distress, fever and voice change. He has fever for 3 days, pulse is high, fever is also high, is there of course, respiratory rate is high, so difficulty in breathing as it says. The child looks cyanotic and anxious, so obviously breathing is difficult, the saturation is not sufficient. Except the soft tissue neck shows compromised airway, narrowed airspace, that's why there is respiratory distress and increased respiratory rate and cyanotic, we understand. Maximum narrowing is seen in the subglottic region. True of this child. So first a diagnosis, then we'll know the correct answer. But choices are child will be more comfortable in tripod position, cephalosporins are the main drug, the toxin released from the pathogen are neurotoxic, none of the above is true. So what do you think is your correct answer first? First you must come to a conclusion so that we can discuss and come to the right answer. So age is very important. 2-year-old child, throat problems, where there is respiratory distress, voice change and fever. So much is the distress that the child had to be brought to the emergency. The child's respiratory rate is high, the child is cyanotic, and X-ray also shows compromised airway. So it's really bad situation in a child with voice change. Now this combination of fever, dyspnea and voice change in a child less than 3 years is a very strong suggestive of Croup. Croup is a very likely diagnosis in this patient, unless proved otherwise it is Croup. Right, and Croup is one of the most common infective disease of the throat in small children at 2 years age. And in Croup is also called laryngotracheobronchitis. The larynx, trachea and bronchus, all the three are inflamed and infected. That's why the narrowing of the airway is seen on an X-ray. And in Croup, the maximum edema inflammation happens in the subglottis. This is a very typical finding. The X-ray finding is a very typical of Croup. And this finding is also called steeple sign. This is called steeple sign. Where the airway is narrowed, maximum airway. So airway is narrow, but as you go towards the subglottis, it becomes more and more narrow like this. So shape of the airway looks on X-ray like this, and this is the shape of a steeple. Steeples are those pillars that are on the top of the churches. Those are called steeple sign. So this is Croup, which is caused by a virus, parainfluenza virus, right? So tripod position is a sitting down position, but Croup, the child is comfortable in lying down position. So this is not true in Croup. This is true for epiglottitis, acute epiglottitis. Epiglottitis child is comfortable in tripod or sitting down position. Croup is lying down. So this is not true. And croup is an infective, it's a viral infection. So cephalosporins are given for again epiglottitis, not for croup. And toxins are not released either in croup, or these are not neurotoxic pathogens, this parainfluenza virus or even Haemophilus influenza. This is seen in diphtheria. Diphtheria causes release of neurotoxins and all that. Not common pathogens like Haemophilus influenza, Streptococcus, parainfluenza virus, and all these. They don't cause toxins. So all the three are not true of this patient, and that's why none of the above becomes the correct answer. In this case, none of the above. I hope you got it right. Now, before I proceed further, I want to tell you that none of the above can be a correct answer in some questions. So don't think that none of the kabhi bhi theek nahi hoga. It's never a correct answer. It is possible to be. So never ignore that choice. It's always a valid choice. So in this question, you basically have to differentiate between croup, epiglottitis, and diphtheria. These are the three acute infections of the throat in most of us. When there is acute infection of the larynx, these are the three most common causes: croup, epiglottitis, and diphtheria. And how to rule out, we just discussed all that. Age is very important. Diphtheria is around 5 years of age. Sorry, epiglottitis is around 5 years of age. Diphtheria is again children, any age group, no specific age. Croup is less than 3 years. And voice change is not seen in epiglottitis. Epiglottitis has fever, dyspnea, and dysphagia, difficulty in swallowing. This child does not have difficulty in swallowing. Diphtheria and epiglottitis both can cause dysphagia. Croup does not cause dysphagia, and this patient does not have dysphagia, not mentioned. So very likely croup. Lot of points to suggest that this patient is indeed having croup, laryngotracheal bronchitis. Next question. A hawker with roadside shop in a very busy market. Please add busy. Market presented with hoarseness of voice. Hawker is someone who shouts and sells his stuff. On the markets you see people, small shops, they're shouting, calling the customers. They are called hawkers. There is no dyspnea, difficulty in breathing. There is no difficulty in swallowing, dysphagia. There is no fever or pain. The only complaint, in other words, is hoarseness of voice. No systemic disease. Everything is normal. Vitals are normal. Laryngoscopy showed a deep red pedunculated growth of about 5 millimeters diameter on the anterior part of the left vocal cord. No other significant finding. True of this patient is: this is Singer's nodule. Bleeding profile of the patient should be checked or investigated. Voice rest is the best treatment. It's a pre-malignant condition. So first you have to make a diagnosis, and then you have to select the correct answer. So very clearly, this is a case of misuse of voice. A hawker is a person who is misusing the voice, who is shouting throughout the day to call the customers, like teachers and singers. So, and such a person who has to speak a lot, shout a lot throughout the day for many months and years, starts having hoarseness of voice. The two things that comes to your mind is vocal cord nodule and vocal cord polyp, isn't it? Vocal cord nodule, which is more common, and vocal cord polyp. So one of the two things is there. From the first sentence we understand. And both this patient will have no dyspnea, no dysphagia, no fever, no pain, nothing, no systemic disease, nothing related. It's just because of voice. But now which of the two is there, you have to know on the basis of the finding. Deep red pedunculated growth. Nodules are very small. Nodules are less than 3 millimeters. Polyps are more than 3 millimeters. This is 5 millimeter. Nodule is bilateral. Polyp is unilateral. This is on one side, left vocal cord. Nodule is at the junction of anterior 1/3 and posterior 2/3. Polyp is anywhere on anterior 1/3. So this is very anterior. So all these points towards a polyp. So this is a polyp, not a nodule. Okay. Why it's a polyp? Clinical presentation is very similar, but finding Nodule, this is only one side, nodule is bilateral. This is 5 millimeters, nodule is less than 3 millimeters. And nodule is, especially at the junction of anterior 1/3 posterior 2/3, polyp can be seen anywhere on the anterior 1/3, which is a case in this patient. So this is a vocal cord, and nodule is not deep red. Polyps are often deep red because bleeding is a very important cause of polyp. Polyp is due to bleeding many times. It's called bleeding polyp. Nodule never has bleeding in it. Polyp often has bleeding. Bleeding polyp it's called. That's why it's deep red pedunculated growth. So it's not a single nodule because single nodule is a other name for vocal cord nodule. This is not a nodule, it's a polyp. And I told you that polyp is due to bleeding. So bleeding profile of the patient should be checked because polyp is very commonly seen in patient who has a bleeding problem. In polyp, the treatment of choice is MLS. Treatment choice is microlaryngeal surgery, no voice change. So this is not true. And none of them are pre-malignant. Neither nodule nor polyp, they're not. So B is the correct choice. In a vocal cord polyp, especially if it's a deep red pedunculated polyp like in this case, patient's bleeding profile has to be checked because bleeding is a very important cause of vocal cord polyp formation. And if you know the bleeding profile, then you can relate the two, and then in the treatment of this patient, you have to also control the bleeding problem. Whatever is the bleeding problem, you have to control or check that. If you don't control the bleeding problem, then the patient continues to misuse the voice, like in this case, hawker, teacher, whatever, then chances of recurrence of polyp is very, very high. So if you don't want to have a recurrence of the nasal polyp or vocal cord polyp, then make sure that the bleeding problem, if it is there, is also controlled, and that you'll know only if you do the bleeding profile and find the cause of the bleeding problem, go to the root of that problem. So that's why bleeding profile of the patient should be investigated very, very thoroughly to come at a diagnosis or conclusion and treat that, right? So why it's not nodule, we know how to differentiate a nodule versus polyp. It's a very common thing in the exam also. And why is not a tumor? Because there is no history of smoking, there is no chewing of tobacco, there is no voice, there is no loss of weight, weakness. All the things are not there, and tumors are never deep red pedunculated. This kind of a explanation of tumors are never, you will have never heard this kind of a description of a tumor, whether it is benign or malignant tumor, deep red pedunculated growth. No, they don't. They are ulcerative, proliferative, pale to pinkish in color, damaging or spreading the tissues, surrounding areas, all that kind of a presentation, not this kind of presentation. So vocal cord polyp it is. And the treatment is microlaryngoscopic surgery. Voice test is an additional treatment. It's not a treatment of choice. It's an additional thing you can give along with surgery. The patient can be advised voice rest and speech therapy also. Whereas in nodule, this is the main treatment. In nodule, this is the main treatment of choice. Okay, next one. Next question. A 9-year-old child was brought with hoarseness of voice for few days. No dyspnea, cough, no pain, no fever, no dysphagia. So no breathing difficulty, no coughing, no pain, no fever, no difficulty in swallowing. There is no significant past history, no significant family history. Okay. Systemic examination is normal, vitals are normal. Fibrotic laryngoscopy showed a warty growth involving both the vocal cords and anterior commissure. Which of this is true of this condition? A. This is one of the commonest causes of hoarseness in children, usually caused by viral infection. Surgical excision is a treatment. All are true. So which is the correct? So first, a diagnosis. In a small child, 9 years, juvenile age group, the only complaint is hoarseness. Everything else is normal. No systemic disease, no family history, nothing. In laryngoscopy, you can see a warty growth in both the vocal cord and anterior commissure. Warty growth is the description for papillomatous growth. Warty growth and papillomatous growth is similar or same thing. And papillomas are very common in children, vocal cord papillomas. And the only complaint in papilloma is hoarseness of voice. In fact, in children, this is one of the commonest cause of hoarseness of voice. So it's laryngeal papilloma or it's called juvenile onset recurrent respiratory papillomatosis. In short, it's called JORRP. So this is the condition from the age, from the history, and the examination finding. It's very clearly a laryngeal papilloma, which involves both the vocal cord and the anterior commissure. And I told you that laryngeal papilloma is one of the most common cause of hoarseness in children. Laryngomalacia is one of the most common cause of stridor in very small children, infants. But this is not infant, this is a juvenile age group, 9 years, 10 years, that age group. So A is correct statement. It is one of the most common cause of hoarseness in children. I told you it's true. And it's caused by human papillomavirus 6 and 11, which is very important MCQ otherwise also. So this is also true. And surgical excision is the best treatment. We either do micro debridement or you can do CO2 laser excision plus antiviral, because it is caused by viruses, so antivirals are also added, but predominantly it is surgery. That means all are true. This is the correct answer. In this question, everything is a correct statement. So laryngeal papilloma in a child where microdebridement and antivirals are given. Now before I jump on to the next question, this reminds me, laser, that very soon I'm going to take, within this week only, I'm going perhaps tomorrow, not tomorrow, Saturday, perhaps on Saturday or maybe Sunday, I'll take one lecture of lasers in ENT. It's going to be a half an hour lecture, and this is going to be in most probably either YouTube or special session that we have on Unacademy platform. So please watch out for that. It could be in YouTube, it could be in Unacademy special classes on platform, but lasers of ENT is a very important topic, so I'm going to take a half an hour session on that. So please watch out and must watch this. Highly recommended. Let's go to the next question. A 35-year-old presented with left earache. There is no hearing loss and no other complaint. Otoscopic examination is normal and the tuning fork and audiometries are normal. The only complaint is earache actually. Oropharyngeal examination showed a small growth on the base of the tongue. On palpation, there was a firm to hard and tender growth measuring 2 centimeters in diameter. Biopsy was taken and sent for histopathology. Which of the following is responsible for the earache in this patient? So basically they're telling you that the only complaint is earache, finding in the ear is normal. Throat, oropharynx has a finding, there's a growth in the base of the tongue. And it is suspected to be a malignant or tumorous, so they have taken biopsy. But why should a throat disease cause pain in the ear, or oropharyngeal disease, base of the tongue disease cause pain in the ear? That's the whole question. And the choices are referred pain by lingual branch of the trigeminal nerve, referred pain by the glossopharyngeal nerve, referred pain by the vagus nerve, and referred pain by facial nerve. So oropharynx, base of the tongue will cause referred pain to the ear via which nerve? Trigeminal, glossopharyngeal, vagus, or facial? And the correct answer is B, glossopharyngeal nerve. See, tongue has 2 parts, anterior 2/3 and posterior 1/3. Posterior 1/3 is also called base of tongue. Now, anterior 2/3 of the tongue receives the sensory via trigeminal, V3 mandibular nerve, and taste via facial nerve. These are the 2 nerves that supply the anterior 2/3 of the tongue, trigeminal is sensory, and facial is only taste buds, not sensory. Posterior 1/3 of the tongue, everything is ninth nerve. Taste is also ninth nerve, sensory is also ninth nerve. Everything is ninth nerve. So if there is any referred pain from the anterior tooth of the tongue, if there is any referred pain from the anterior tooth of the tongue, it has to be trigeminal, mandibular nerve. And if there is any referred pain from the posterior 1/3 of the tongue, base of the tongue, it has to be ninth nerve. So this has to be ninth nerve because it is base of the tongue, posterior 1/3 of the tongue. But the question is, does the ninth nerve also supply the middle ear? Because it has to also supply the middle ear. And the answer is yes, middle ear is supplied by the Jacobson branch of the ninth nerve. Jacobson's, writing here. Jacobson's is a branch of the ninth nerve that supplies the middle ear also. So same nerve also supplies the base of the tongue. So there is a common nerve, and therefore there is a referred pain. I told you trigeminal can cause referred pain in the ear from the anterior 2/3 of the tongue. Then vagus can cause pain in the ear from the larynx because vagus supplies the larynx. And facial nerve does not have sensory supply except very small skin in the canal, so it cannot cause a referred pain. Facial nerve cannot cause a referred pain because it is not a nerve carrying pain fibers. It does not have pain fibers. It has taste fibers, it has parasympathetic, it has motor. It has pain fiber, but that supplies only one area, canal. So there is no other area, so it cannot refer. For referred pain, you have to have same nerve must apply two different areas. Only then you can have referred pain. If it supplies one area, it cannot refer, right? And even otherwise, it supplies a very small area in the canal, and it is very insignificant also. So it is almost not there. You can say it is almost not there. Sensory supply of the facial is absent almost. So it cannot cause referred pain. Okay, but facial nerve is the most important nerve, cranial nerve from the ENT point of view, that I'm sure you know already. Next question. A patient presented with aspiration off and on. He also has difficulty in speaking in high-pitched voice. There is no dyspnea, dysphagia. The patient is known case of uncontrolled diabetes for a long time. No other complaint. Systemic examination is normal, vitals are normal. Laryngoscopy showed bilateral mobile vocal cord. Mobility is normal. Left vocal cord appears loose, so tension is gone. Opposite of tight is loose, and it's hanging downwards. Which of the following nerve is paralyzed? So this is a vocal cord paralysis. Which of the following nerve paralysis gives this kind of a presentation? Is it external laryngeal nerve palsy? Is it superior laryngeal nerve palsy? Is it recurrent laryngeal nerve palsy? Is it vagus nerve palsy? So what do you think is the correct answer? Now, before we come to the answer, let's discuss. See, I just told you larynx, this is larynx, is supplied by only 10th nerve, vagus. Why are two branches? Superior laryngeal nerve and recurrent laryngeal nerve. Superior then divides into two branches. One is internal laryngeal nerve and one is external laryngeal nerve. Recurrent is a mixed nerve. It also divides but not so clear. So ultimately we have three nerves: recurrent, internal and superior, external. Now, internal supplies sensory to supraglottis, and so it helps in controlling the aspiration. So if this is paralyzed, aspiration is a possibility. It can give rise to aspiration. External supplies only tensor of the vocal cord, cricothyroid muscle. So if this is gone, low pitch voice and loose vocal cord, loss of tension. If this is gone, this mainly supplies adductors and abductors. This mainly supplies adductors and abductors, and if this is paralyzed, there is hoarseness of voice. Hoarseness. So this is how you conclude. How do you come to a diagnosis in case of vocal cord palsy, which nerve is paralyzed. So if aspiration is there, then chance of internal laryngeal palsy is very high. If low pitch voice or loose vocal cord is there, then chance of external laryngeal nerve palsy is very high. And if there is hoarseness of voice, then chance of recurrent laryngeal nerve is very high. And if a combination of all, then all the nerves are paralyzed. If the combination of two, then two nerves are paralyzed. Now in this patient, according to the history, we understand that this patient has, what are the symptoms in this patient? The patient has aspiration, yes or no? Here, aspiration, and low pitch voice, cannot raise the pitch of the voice, and loose vocal cord. So this nerve is gone and this nerve is gone, but no hoarseness. So this is not gone, this is normal. So when these two are gone, this one is gone, because when this goes, both are gone. Therefore this is clearly a cut of superior laryngeal nerve palsy. That's why both his branches cannot function. One leads to aspiration, the other leads to low pitch voice. So the answer is superior laryngeal nerve palsy. I hope it's clear to you. So this is how in external laryngeal palsy, only low pitch voice, there will be no aspiration. In this patient, there will be no aspiration. If it is recurrent nerve palsy, the main complaint will be hoarseness of voice. If it is vagus, then everything, hoarseness of voice, low pitch voice, as well as aspiration, everything will be there in vagus, because vagus, everything is controlled by vagus ultimately, like it's the headmaster. So when you get a vocal cord palsy question, this is how you have to approach this patient. So if you can remember this chart of nerve that I've told you, if you can remember this flow chart kind of thing, it helps you but these are it helps you come to the conclusion very easily. Now there is a 2 points of precaution here. Number one, I've only told you the main symptom of each of the three nerves: aspiration, low pitch, and hoarseness. But along with that, there are other cough, dry cough, things like that. There are a few things there. And the second point is that vocal cord palsy is not only due to nerve palsy. Vocal cord movement happens at the joints. So joint problems like arthritis, for instance. So with rest of the joint problem, the vocal cord joint can also get affected. Or some tumor invading into the vocal cord muscles or can cause palsy, movement, voice change. So vocal cord palsy is not always because of nerve palsy. But when we use this term vocal cord palsy, we invariably mean it is due to a nerve damage, one of the three nerves or all the three nerves damaged. Otherwise, we don't use the word vocal cord palsy. Hoarseness of voice can happen without palsy also due to trauma to the movement of the vocal cord, due to other conditions like, as I explained, joint problems, growth problems, invasion problem, things like that. Okay, next one. A young college student met with roadside accident, following which he had head injury and went into coma. He had to be admitted in ICU. He was unable to breathe spontaneously and so was intubated and put on ventilation. After 6 to 7 days, it was realized that the patient will need ventilation for a few more days. So which of the following is the best option now? Basically, the patient is in a coma, is not able to breathe properly, so it was put on ventilation and intubated. After a week or so, we realized that patient still has to be on ventilation because breathing has not resumed. So what should be the best? What is the best option? Should we continue the same way, that keep the patient intubated and on ventilation in ICU, or we change the intubation tube, remove the tube, put another intubation tube and put on ventilation, or remove the intubation tube and do tracheostomy instead, or do a cricothyroidotomy instead of intubation? So which is the best option for you? And the correct answer is C. See, one of the indications for tracheostomy is long-term intubation. If you have to do long-term intubation, which is more than 5 to 7 days, long-term is, if you have to keep intubation tube for more than 5 to 7 days, then we don't do intubation, we prefer to shift to tracheostomy. In the initial stage, when the patient first comes to the ICU, and only that point you realize this patient is going to be intubated for more than 7 days, then we don't intubate at all. We just do tracheostomy straight away. and after we intubate, for instance, and after a few days we realize no, it is required, intubation is required for more period of time, maybe more than 5-7 days, then we change it, we do a tracheostomy and remove the intubation tube. So this is one of the indication for tracheostomy, long-term intubation, because long-term intubation can cause very serious problem of A, intubation granuloma, and B, intubation stenosis, you call it subglottic stenosis. Now these are the two very important problems that can arise due to long-term intubation, and both are extremely difficult condition to treat. They may not be very serious problems, but you can't treat them, almost impossible to treat. The recurrence rate of both are very high. So it is best to avoid such things. Diseases that you cannot treat, the best thing is to avoid such conditions. And with this in mind, we don't do intubation for long duration, we instead do tracheostomy. That's the whole logic behind this. Okay, so C is the correct answer. Next one. A 65-year-old chronic smoker and alcoholic presented with hoarseness of voice, no dyspnea, no dysphagia, he had some weight loss, there is no other complaint. Vitals are normal. Laryngoscopy showed a proliferative growth involving left vocal cord, false cord, arytenoid and AE fold. Histopathology proved to be a squamous cell carcinoma. It was decided that the patient be operated followed by radiotherapy. So the treatment decided was surgery followed by radiotherapy. Best surgical option: total laryngectomy, horizontal partial laryngectomy, vertical partial laryngectomy, and subtotal laryngectomy. Basically, we know that there is a carcinoma in the larynx. That's why there is a hoarseness of voice in 65 years old. And the involvement is left vocal cord, left false cord, left arytenoid, and AE fold, left side. So with this involvement, what is the best surgical option? So when I draw the vocal larynx like this is vocal cord, this is false cord, and arytenoid and AE fold also in the neighboring area. So the involvement is like this. This is involved. Tumor is like this, left side. And see this, between the two lines, this area is glottis. See, this tumor is involving the glottis and supraglottis, isn't it? Glottis is between the two lines, above is supraglottis. This area is supraglottis, and below is the subglottis. So clearly the tumor is glottis and supraglottis. When two areas are involved out of the three, it is called transglottic growth. So this is transglottic growth. What is transglottic growth? Out of the three, at least two areas, either subglottis and glottis, or glottis and supraglottis, or all three, transglottic. Basically, this line that I've drawn, if the tumor crosses this line, another two line, it makes transglottic growth. And so in transglottic growth, vocal cord is always involved, glottis, vocal cord is always involved. Now, because it is one-sided tumor, why remove the other side? So total laryngectomy is not an option. This is also not a, subtotal is also usually not. Subtotal is hardly ever done, right? So we have to do a conservative laryngectomy, but should we do a vertical partial? Vertical is like this. Vertical is cut like this and cut like this area, vertical. Or horizontal partial. In horizontal partial, we don't remove the vocal cord. We remove the above the vocal cord, this area. This much if you remove like this, that becomes horizontal partial, because you are cutting above the vocal cord like this, horizontally. So if you do a horizontal partial laryngectomy, then you are not going to remove the vocal cord part. So it's not a complete surgery. And that's why vertical partial hemilaryngectomy, where you remove the supraglottis of that side and the vocal cord, glottis and supraglottis of the same side, is called vertical partial laryngectomy. So this is the correct answer, right? So why not horizontal partial? Because the vocal cord is involved. If the vocal cord was not involved, suppose this was not there, if this was not given, this much, everything is same, then the answer would have been horizontal partial hemilaryngectomy. Because in horizontal partial hemilaryngectomy, we do not remove the vocal cord usually. Usually we don't remove. In vertical partial, we remove the vocal cord also, right? So why not total? If the disease is confined to only one half, why remove the second half? And subtotal is very near total. Only one of the joints is retained. So again, subtotal and total are very, very close to each other. And I just told you subtotal is useless. We don't do subtotal anymore. It is just in theory. If we have to do a subtotal, we prefer to do total instead. So total is better than subtotal. So this is about laryngectomy. And laryngectomy is another very important topic. I've taken a special class on laryngectomy already, and all the types of laryngectomy, how are they different, what are the indications, what are the complications, advantages, everything I've discussed in the special classes. So you can go back if you are interested and look at that particular video of the special class with laryngectomy in it. So that completes the 11 questions that I had to discuss in throat, and this gives an idea what kind of clinical based question can be asked in throat. So that was the whole idea behind this. So I hope this was useful for you. It was certainly pleasure for me to talk about this kind of questions and brief you what kind of clinical questions they can ask in exams, because these days clinical questions are very commonly asked. The patterns are changing, they are changing times. But before I leave you, I must tell you about this once again, repeat about this Focus NEET PG 2022. As I told you that this is targeted towards next PG, next NEET PG. So people who are in third, fourth year especially, or new final year, towards them, the course has already started in August. All the 19 subjects we are doing with ENT is going to start on the 14th of December ENT to 26th January, 30 hours of ENT. So if you have not joined already, I'll highly recommend that you join this course. Very, very useful. This is that very famous subscription called Iconic Subscription, where we give Unacademy Subscription plus an app. So you get both the things, best of both the worlds, And in this, there are many packages, different kind of packages for. So whatever can suit you, depending on your budget or your requirement. And you can get all this information in the Unacademy platform, the website. So you can go there and look for it, check out, and if it suits you, go for it. And we have this marathon batch, MCQ based. This is targeted towards this NEET PG 2021 January. And here we are doing all the 19 subjects, MCQ pattern, and very short duration each subject, as the name tells you, marathon. So it's a marathon run for you. It's especially targeted towards last moment revision, people who have done their studies and they cannot revise, what to revise, what not to revise. It's very confusing time, last moments. So we have come up with this marathon batch. We will teach you all the batches, and in MCQ format, we are going to deal with all the important topics and points. Like in ENT, I'm given only 5 hours. But in 5 hours, I'll ensure that we cover all the important topics of ENT. So 5 days starting on, ENT starting on 30th of November, ENT. 1 hour each, 5 sessions. Okay. Likewise, all the 19 subjects. So very, very useful for people targeting 2021 NEET PG for the last moment revision. So with this background, I leave you. I thank you and wish you all the best for your future. So look out for other YouTube videos and special classes of ENT. My next YouTube video is going to be on image-based question, which is going to be a 30-minute video. And I told you already that next special class is going to be on, one of the classes is going to be on laser, and one class is going to be on salivary glands. Today evening, yesterday we had this salivary gland tumor, so you can check out on the video. So thank you once again. All the best. God bless you. Take a very good care of yourselves. Bye.